Thank you for the invitation, and some of you heard some of this talk already on Friday on the scientific section, so I hope it won't be very boring. The repetition, my conflict of interest is that I'm a PI on the current glycomine study, and I was PI for the aporestat study. So you all know that congenital disorders of glycosylation have very significant effect on central nervous system. And even there are some CDGs which are progressive and not improving, but can go reverse way. No FDA-approved treatments. There are so many unmet needs. So what I try to show today is a collection of N-of-1 studies which give us hope that even in rare disease we can develop new clinical trials, and what we learned from the ones we did so far. So I start with this fun example. PGM1 CDG. We heard an amazing talk from Hayden about PGM1 CDG, so I don't even discuss the biochemical background. But what you see here on the picture, that PGM1, the enzyme itself, it's connected to glycosylation, but also connected to muscle function. So there was a Chinese group who, who encountered a patient who had myasthenia. And myasthenia is a disease when you lose your muscle strength because somehow that junction, which is between your nerves and the muscle, and you see that those little vacuoles in your nerves, they have acetylcholine in them, and so you release that to send a message to your muscles, hello, work, and contract. And so in myasthenia, that's not going well. So what these researchers or these clinicians found in their one patient is there was a myasthenia in their patients, and the patient got weaker and weaker. And they used a medication which improved this acetylcholine action between nerve and muscle and significantly improved muscle work. Why is this important? Because this is actually a problem in many CDGs, not just in PGM1 CDG. We know at least 8 CDGs where this can happen, and the drug, mestinone, is working on this specifically, keeping the acetylcholine longer between the nerve ending and the muscle. So there are several patients who are on off-label treatment with mestinone, and we know for PGM1 specifically that there are 4 patients already who are doing really well. And this was really just a serendipity of one of my colleagues reading this Chinese paper, which is really in Chinese, so we needed help to read it, and brought benefit to several patients. Another serendipity finding is in GMPPA CDG. This is a CDG which causes a lacrima. It means that it's very hard to make tears. And if you make tears, even after making the tears, they disappear very fast. So we know another disease with a lacrima. It's N-gly1 CDG. And in patients with N-gly1 CDG, we observed that one special sugar we call glucnoc, or N-acetylglucosamine, can reverse tear production. So, okay, this is not exactly the same disease, but what can go wrong with trying a little bit of sugar? So we tried in 4 patients with GMPPA CDG, and we added this glucnoc sugar to their diet, and they all experienced improvement. Some patients just got a little less stress of their cornea. Some patients had measurable increase in the tear film on their eyes. So it's variable, but definitely made a difference. So little observations could bring you benefit in quality of life in CDG. Now, I want to mention another approach, how you can come up with ideas of finding new therapies. And we have been talking about using AI and predicting medications for certain CDGs. So Thomas and I and our and postdocs in our lab are working on different CDGs and then making these cerebellar and cerebral organoids, which are patient-derived cells, like Hayden presented to us, how he made like heart cells from skin cells. We can also do that for brain cells or neurons. So when you have those, then you can use those to measure glycosylation, measure gene expression, measure pathways. So by measuring and creating a whole lot of data, you can use machine learning and AI to figure out what does that data tell you about the disease. So we had two interesting findings in ARCH13 CDG, that we saw that the pathways, which are related to retinoic acid and its vitamin A, or a form of vitamin A, was down. So there was not so efficient retinoic acid synthesis according to the data, what we measured in the mini brains. And then in a few patients, we measured retinoic acid, and we found that it's low or low normal. So that gives us a new potential treatment, which is not without danger, because high vitamin A intake could cause a problem, but could bring us a potential new treatment for ARCH13. And then we did another approach for ARCH13 and for many other CDGs. We used AI to predict some kind of treatment for us. And just giving you an example, in ARCH13 CDG, we asked AI, there's a lot of data out there about genes and gene expression. There is also a bank of data for cancer cells and their expression and pathway analysis. Could that help us to predict something for ARCH13 specifically? What we found is that potentially there is an abnormal acidification, which is part of the CDG pathway. And if it's abnormal, then it can cause to further glycosylation problems. And there are treatment options for acidification problems in CDG. One example is acetazolamide we use in PMM2 CDG patients. And so another drug which has similar side effects of changing acidification is Topomax. So we changed some of our ARCH13 patients' medication to Topomax, because then it's still an anti-seizure medication, but it has some benefits for the CDG. Now, I'm going back to the eparestat trial, and please excuse me if you heard this part of my talk during the scientific talk, but some of you were coming just later and not here on the scientific day. So I would like to just go back and do a very quick recap on what we learned from the trial when we looked into aldose reductase therapies in PMM2 CDG. You remember the story started with drug screening. So what Icahn did, used a worm model. So the worms had PMM2 CDG, and cultured these worms and grew these worms and plenty of plates. And then the worms were not very happy because they had PMM2 CDG. But when you sprinkled some of the medication, some worms actually recovered quite well. And you see not all the worms survived because some of the medication had no effect, beneficial effect for them. But eparestat came out as a potential treatment option. And you have to know that eparestat is a cinnamon-like compound, but it's also an aldose reductase inhibitor. Aldose reductase is an enzyme. And so I made a little figure to make you understand what aldose reductase does. And so here you see your favorite green monosugar. Here is PMM2 CDG. This step between these sugar forms is blocked. And you see, actually, aldose reductase is here quite far away from the PMM2 deficiency. So why would all those reductase inhibition help us, actually? If this is true, that this would be the enzyme of choice, then I probably would measure also sorbitol first, because if this is going up, the flux from sugar to sugar alcohol is increased, then this should be elevated. So first we measured actually the enzyme deficiency, and then we measured the sorbitol levels, which was elevated, and we also measured glycosylation, which was decreased. And then, indeed, this sorbitol, what I mentioned to you, was increased in fibroblasts and also in urine of patients. So we thought we have a good story. It seems like this makes sense. And so let's see if I'm blocking all those reductase, what will happen? Obviously, if you block the pathway from glucose to sorbitol, the sugar alcohol, that will go down. That's very good because sorbitol is toxic for your nerves. And then you will increase the flux from one sugar molecule to the other. That is very good because that makes you a lot of glucose 1,6-biphosphate, and that's a well-known activator of the PMM2 enzyme. So if this is all true, if it's all true, then we are in business, guys, because we will decrease a toxic metabolite and increase the PMM2 activity just by using one aldose reductase drug. So we were very excited to start this trial, and the single patient measurement showed significant improvement of glycosylation in serum for our index patient from here to here. This is a patient who got liver transplantation. And so after we had the initial patient on the trial, we randomized 38 patients to the trial. 15 months, these patients were coming regularly to a single site, traveled in winter, in storm, in kids' sickness. It was amazing what the community did for making this trial successful. And then we ended the trial after 15 months because it seemed like there is no significant improvement in the treatment arm. How is that possible? How is that possible? We had so great hypothesis, great screening, great preliminary, single patient showed improvement. It seemed like it has to work. So what we did, we used this Icahn scoring, and I think most of you are familiar with that. It has a gait analysis part, and it has a physical exam part, and also we are drawing this Archimedes spiral. And so all the patients who were older than 4 had this as an outcome measure. So when we looked into the data, what happened to the patients, then first we just did look into the patients who had severe autism or intellectual disability. And if you look at these patients, and that's a quite large number of patients, you will see that most of them had no change in their ICARS. It's pretty much nothing. So one mistake we did at the beginning, that we didn't select the patients who were able to perform ICARS, because the autistic patients just didn't follow our commands, and they didn't really do what we asked them. Sometimes they couldn't walk, or they didn't want to walk. So we actually diluted the patient population with patients who were not recruitable from this outcome measure perspective. Then if you just look at the data itself, then you see here 25 patients altogether, and you see there is no difference between the ICARS numbers on placebo and on treatment. When you compare these, there's extreme variation in the treatment group, but also you see that actually they are not significantly different. However, if you look into this little box, you see that there were super responders. There were patients who responded to the drug extremely well. So then we made a hypothesis that maybe not everybody would improve on eporestat, and maybe we should figure out who are the patients who have a future with trying all those reductases and get better. Another aspect I would like to mention is just very briefly that Ethan Perstein sent us these pictures. He is actually still on eporestat as an off-label treatment. And what you see here, he's not a super responder, but after 3 years on eporestat, he did learn to make steps in individual steps. And I think that the reason behind that eporestat decreases polyol production, and he has extremely good physical therapy. And so because of that continuous therapy and because the polyols were normal in him for a longer period without increasing, what's naturally increasing in our PMM2 patients, he didn't get a worsening of his neuropathy, so was able to improve. And then just finishing this part quickly with how we try to figure out, with the help of AI, which are the mutations which should be amenable for aldose reductase therapy. And you see here a list, and so we ruled out severe loss of function, glucose 1,6 biphosphate binding site variants, linker region variants, magnesium binding variants, and even some of the folding and dimerization variants based on the AI prediction using AlphaFold and some functional studies. If you do that, that's kind of sad to see that only a few mutations remain. We could include theoretically, but that is just those mutations we included in the study. There are several other mutations which could be amenable, but for our own cohort, these are the mutations which are predicted to be amenable for aldose reductase therapy. And so this is lovely because the 2 dots here show that if we only include these patients and compare to placebo, where we also ruled out the same not amenable variants, then you can see a statistical significance. So maybe there is a specific genotype-related response to aldose reductase inhibition. So I think that's a positive note, and what we would like to do is go into the literature, use AlphaFold and structural biology to predict who are those genetic background carriers who could use this drug or these drugs, because there is also applied 007, which could be used in the future. And this is just, I promised someone from the audience to show the side effects. And so, indeed, there were side effects there were adverse events, sorry, not side effects, in the eporestat study. And if you look at the 2 columns, you see that actually infections were the biggest thing. That's the purple, or I don't know what is that color, burgundy color. But obviously, we cannot be sure that that's a side effect of eporestat. We can just say that there was increased number of infections, and there were more infections in the treated group. But when you actually take off the single patient who was very, very severely ill and we lost during the trial, then you see that actually the adverse events are pretty much comparable in the 2 groups. So what did we predict wrong in eporestat? Because we should use this in our next studies. We included everybody without selecting patients who could actually do the test, what was an outcome measure, and we just said, all welcome. We didn't have a good chance to try out outcome measures because we had to go from single patient IND directly to placebo-controlled double-blind. And so antithrombin failed as an outcome measure. And there was one more thing. We asked our patients to have fasting labs, which was not possible. And that was really silly of us because obviously you guys cannot keep your kiddos fasting just for labs. Okay, so let me switch. I have a short time before I have my future perspective coming to join me. Just go to the DHDDS story. I think we talked about the DHDDS and N-of-1 a little bit already, but maybe just go back to this really interesting new condition which might have one treatment already. So here's the block, and this is fat synthesis. So you will have this short fat, which will go to longer fat, and it will further develop to a perfect structure. And when you have that fat, then you start to collect the sugars one after the other, and you make glycosylation possible. So it's a very early defect, and it disturbs not just glycosylation, but fat metabolism as well. So here's the block. And here you see the symptoms, and you see many of the symptoms are shared with other CDGs. There are a lot of the delay, the speech problems, the seizures, ataxia, movement abnormalities. And here you see Rosie, who offered to show her video from, I think this is like more than 2 years ago, when she is trying to do this gait test where she has to put her heels to toe and try to keep her hands close to her body. And so this is like a disease which affects mostly the central nervous system. Drug screening was done by Icahn group in yeast. The same idea that we culture the yeast and then we have multiple plates and then sprinkle different existing medications on the yeast, and some yeast die, and because they have the mutation, right? And if the medication doesn't work, they just die or they don't grow anymore. And there is a yeast which survived, so that's very, well, it's a happy yeast day. And then especially when the drug, which was found to be leading to this positive outcome, is a vitamin. N-of-1 is a form of vitamin B or niacin. So it's actually a molecule we are swallowing every day in our food, but not in such a high concentration. So when we got this result, then we were thinking, should we just directly give it to patients because that's a vitamin, or should we check if it has benefits in our organoid model system? And I already showed you how to make mini brains from fibroblasts of patients. And so we use these mini brains to study their biochemical measurements and see if we can measure benefit for N-of-1 when we add the N-of-1 to the growing organoids. And so what we saw, that there was a mitochondrial dysfunction, so energy production was down, and then we gave the N-of-1, and the energy production went up. So then we said, okay, we love this, and let's see if we can use that in the clinical practice. So far, more than 6 patients went on oral off-label use of N-of-1 with the autosomal dominant DHDDS CDG, and did all the tests. And you see an example here. Rosie is drawing. You see how her hands are shaking, how difficult to make a smooth movement. And there's another video a few months later. And I think you all see that she improved. But how can I measure that? How can I tell the FDA that this is an improvement? So one of my colleagues, Irina Muffles, tried to make sense of it by quantifying the movement disorder. And here you see a healthy individual walking, and you see there is almost no tremor. The hands are close to the body. The feet are, it's a little speed up, obviously. The feet are really close to heel to toe. And you see that line, it draws a line here showing the distance from the midline. So what you see is him. This is right hand, left leg, right leg. It's a nice aligned movement pattern. Then if you look at Rosie one more time, and this is years ago, you see how different that is. And you see that the arms are so far and shaking. This is like really different, the two from each other, right? So what do you think, how did we do it? Irena sat down and frame by frame of the video just made the measurements and put together this file, right? This is insane. So, I mean, amazing of her. And a good postdoc, insane, amazing. And so what you see here is the same video for Rosie, and then you see her a few months later, and then you see an amazing difference here of her arms, how much she needs to balance to accomplish the same task. So this is a way of measurement, and I would like to say that that made me think that this should be done better. Because if we could do this, then you don't have to come to me to see me at clinics. You can just send me videos from home, and we have a Zoom, and we discuss what's need to be done. I have a clinician partner who's living close to you, and I asked, like, could you do safety markers, measure whatever is needed in the blood, do a physical, and give me that information, and you don't have to travel and get all that misery. Okay, so, but if we want to do that, then we have to convince the FDA that this is the future of clinical trials. So, to give you good news, we already submitted an IND for the DHDDS trial, and the FDA accepted our outcome measures of virtual, which is like insane. It's like, have you heard that? So we will do a proof of concept trial with trying to see patients as little in person as possible. But then I met Ben, and Ben is a data scientist, and he understood that we have to do this like really well. Like it should be totally objective, because I'm not seeing you anymore to say, oh, this score is 2 or 2.5 or 3, do you agree? But it's just a video which goes into machine learning, and the machine will say, yes, you improved. So it has to be done just well. So come, my future perspective, and take over.
Well, thank you so much, Eva. That was such an amazing talk to lead into what I wanted to speak about. Wanted to thank you and the organizers for inviting me to give an opportunity to speak, and also for Eva to involve me in this very exciting work. I'm going to do exactly a segue to what she's talking about. First, I'll take a little bit of a step back to give you just where I came from and my perspective to all this, because I came from a very different background. And I just want to also add that being here and seeing the families and seeing your children is very important for me. I'm not a clinical practitioner. I'm a data scientist. I'm an AI faculty, and I have 2 daughters under 2 years old. So me being able to contribute, me being able to help and just do anything I can to help our amazing clinical practitioners help your children is especially meaningful for me. So before I start, here is my industry relationships. So from my perspective, I've been in kind of the medical AI space for a long time. And what I see, and maybe you see, is every day there's another headline about how medical AI has cracked it. It's solved this, it's going to be replacing doctors, it's going to be doing everything. But invariably, a couple days later, a couple months later, there's always the other side of the coin here, where there's a lot of hype, and then the hope just doesn't live up to the expectations. And I want to argue this is especially problematic in children's health, Because in adult AI, we even have a lot of data in cardiology, in radiology, in oncology. I mean, these are awful diseases areas as well, but there's a lot of data that has been unlocked. And in these fields, you can create models with these data pretty handily now. However, time and time again, we know that the framing, children are not little adults. And when you build models in adults, it may be obvious, but it's very true that AI does not work when you try to translate them into children. And that means we need data like this to be able to build our own models and generate and work really leanly and efficiently to build models that are specifically personalized to children, especially with rare disorders. This is kind of how I think about being in the field of clinical AI for a long time and stumbling and falling into pitfalls and issues time and time again. Clinical AI is built from the chart. It's not really built from the patient. And what I mean by this is when Eva, other clinical practitioners here are seeing your children, they are taking the state of what's happening and they're breaking down that state into the prerequisite fields in electronic health records. This is how operations work, what medications, what diagnoses, what lab tests, etc. As a data scientist, I don't see the patient, which is probably a good thing, but I see the data and I try to build a reconstruction of the patient from the data. And this is highly imperfect for a lot of reasons that you can probably already tell. Number one, we don't see what happens and we don't hear what happens in between visits. We don't see when a child went to another specialist and that data does not get into the chart. I can't come up with that signal out of nowhere. There's a lot of missingness and bias that happens when we try to build data from routinely collected variables. So really, if we think about it, the hardest part is we talked about how multifactorial and how many aspects of omics and modalities are affected in CDG and other rare disorders. And health state is complicated. There are many layers to it. And the crazy thing is that it changes constantly, especially in childhood, right? The amount of changes that are happening across all these very, very diverse aspects, immune system, gut health, gut microbiome, are happening on such a fine-grained resolution layer, and we're just not capturing that. One thing that's been really great, though, that the field of clinical AI has been embracing is the idea that if you can get aspects of these multiple dimensions of data, it can reduce a little bit of the bias that's happening from what I was talking about before, which is the imperfect nature of structured and standardized data that's coming into the chart. So this is what I'm really, really a big believer in now. And especially I'm trying to think, where could it have the most impact? Let's think about, Eva talked about these standardized scales. I think about these scales a lot because these scales are kind of what I see. And they're very useful, right? If someone comes into the ER and they say, I have a pain in my chest, that's an 8 out of 10, that allows for very quick resolution and potential action. From my perspective, though, that 8 out of 10 could mean so many different things. And like how the patient was, the pallor, the color, the facial expression, their labored breathing, all of that, a physician, a clinical practitioner is seeing gestalt of that patient in the first 30 seconds. A lot of that goes into their natural neural network to make some kind of decisions and ideas, and some of that gets into the chart, but a lot of it doesn't. And so we really have this problem in clinical AI where there's a ceiling. There's a barrier that exists where models just cannot work. This is a personal belief based on insufficient data availability, and I would say most importantly, representation of the data. If people are familiar with the Silicon Valley at all, I have to give them credit. The advancements in video AI over the past 5-10 years has been unbelievable. Video AI is revolutionizing autonomous driving. Tesla, Waymo, they're making millisecond multimodal predictions for real life driving. These are things that are in practice. These are live in the streets, but very absent in healthcare. Why aren't we using these technologies, these incredible technologies, to analyze very complicated health state data better? And this is where I can hopefully come in and help. When I talked to Eva, she was describing this problem, and I'm not going to go into this at all. But I will say that this has been a partnership between her, myself, Matteo, who's an engineer, and Rory, who's a clinical scientist, practicing physician scientist in the room. And we were talking about this constellation of symptoms. And we were talking about the way that it was being recorded, this Icahn score. And we were really thinking about this, for instance, walking capabilities, 7 out of 8, 5 out of 8. That to me sounds a lot like pain score of 8 out of 10. Why can't we do better than this? Why can't we leverage these technologies to do better? When Eva told me that she had the foresight to get video data on her patients with consent to be able to even start to think of this, I was blown away. This is the thing that doesn't exist in my area. People, prominent leaders like her in other fields are not thinking this way and not creating data that we can learn from. I could not believe she had the foresight. I would call her a data scientist at heart, because this is the exact things that we need to build off of. So what did we do? We took this gait assessment, the 10 feet or so walking test, and instead of having to painstakingly, manually every frame do it, why don't we let postdocs use their brain for better things? Why don't we use AI for something good, right? So what we did is we applied a open source model to annotate all of about 14 or 18 landmarks. And what it's saying is basically, this is predicting where the left hand is, this is predicting the left ankle, this is predicting the left hip, and different facial left eye, etc. And we can create these anatomic landmark maps on a single frame. We can also get derived features, so not just those anatomic landmarks, but how much is a person leaning? How much are they tilting? What is the relationship between these anatomic landmarks together? And now, if we could look at movement, how do these anatomic landmarks change? So how does the movement of the left hand change during this assessment? And what we can do from this is, instead of having a assessment of a 7 out of 10, we can have this for every one of her patients, which is a living map of all of these different anatomical landmarks moving in space, producing orders of magnitude more quantitative digital biomarkers that we can analyze. There is a wealth of data for each video that we're only scratching the surface of. This is only really the beginning of what we can do with this technology. So the study was led by Rory. I think he is in the room somewhere, but this light is making it so I can't see. But him and the team and I worked, what I would say is just scratching the surface. So it's really, first what we have to do is we have to compare these metrics. These are just movements in space. We have to ground them. So first we have to compare them to the standards. Is there any correlation? I at least hope so. I hope it's not a perfect correlation, because otherwise we're not learning too much more, but I hope there's some grounding. And then let's see, this is what I really care about, can we measure treatment effect on a much more higher fidelity scale? So the first thing that we showed is, when we look at pre-baseline and post-treatment for a lot of these patients, we generally see, as Eva was alluding to, a change, and we generally saw that for certain metrics of what we're recording, we see a correlation in the same direction. So what this means, for instance, what we can see here on the bottom left, we can compare every derived metric with specific Icahn subcomponents. I don't think it makes sense to compare the verbal aspects of an Icahn for this. I can't see a world where that's going to matter. But what's really great is the ICARs for posture and gait was highly correlated with one metric that we found important, which was body lean. How much is the body leaning during this gait test? And so we can also see, this challenge of, for the FDA, how do you showcase that something is working? When you have a crude representation, it's really hard to show significant effect just because the numbers are so crude. When you have a more fine-grained quantitative biomarker, statistical models typically like that better. And so we're able to show significance in a much more fine-grained way. So in my mind, this is what I would like for us to be able to generate in a quantified and robust manner. To be able to have clinical practitioners like Eva to be able to use something like this. Instead of having to think, well, on day 0, the score was this, and on day 5, the score was this. Obviously, we know no observer is perfect. For my 4-month-old daughter, I can't even remember what she sounded like a few days ago because my mind is blocking out a little bit from sleep deprivation. So how to remember 30 days ago what happened is so challenging, right? And also we know there's a lot of inter-rater reliability. We know that 2 people looking at the same thing with the same rules will interpret it slightly differently. So instead of having something like that, what I'd like to have is more of a map. So we can look at things like wrist symmetry, right? How much does the symmetry of the wrist change between before and after? How closely they're together. We can look at this for all the anatomical landmarks. We can also look at the derived metrics like tilt and lean. We look at the average lean during that walking assessment, and we can see that there's a much significant reduction in lean pre and post treatment. And what we can also create is, instead of this one-dimensional score, we can really make it a kind of a personalized assessment, where for each patient, this is this is derived for just one. We can make a visual thing that the clinical practitioner and the parents and the care team can see, which is across all of these metrics for your child. This is how much they were, for instance, leaning, their stability post-treatment. It didn't change too much. However, there was a lot of improvement on tilt stability. This is just a different aspect of how things can be monitored. So this kind of more personalized view into treatment, I think, is going to be hopefully more informative and allowing this more information both to be utilized to the FDA, but also just helping understand the unique situation for each one of your children, because even though these are rare disorders of the same type, they obviously manifest very differently. Last thing I'll say, in my bonus last 1 minute, is this is another aspect with which Eva alluded to, which is this coordination test in the Archimedes spiral. This also is a very useful test, but the way that it's scored is still somewhat crude. So this is one of Rory and Eva's trainees, another physician scientist, Daniel, made an app that allows for the tracing of the Archimedes spiral via an iPad. And what this can allow is orders of magnitude more quantitative assessments of the test, like how much the finger are going up and down, the speed, the actual pixel level deviation from the main spiral. All of these things you can't get for a 2 or a 3 score from this. So we actually have this iPad here. If anyone would like to participate, please come to see us during the coffee break. And with that, I would like to thank again Eva and Rory and the team for allowing me to be part of this, and thank you all again.